Good afternoon, everybody. Thank you so much for joining us for today's Leaders Initiative seminar. My name is Stephanie, and I will be monitoring things here on the back end. Just a couple of announcements. Our next Leaders Initiative talk will feature Dr. Mercy Best. It will be held on April 14th at noon, and she will be presenting Unraveling the Complexities of Progressive Spironuclear Palsy and Frontotemporal Dementia. So be sure to mark your calendars for that. Towards the end of this talk, I will be sending out a Qualtrics evaluation, so please take the time to fill that out. We would love to hear what topics you're interested in hearing about in the future. And with that, I will turn things over to Courtney Polenic to give the introduction.
Thanks, Stephanie, and thanks everyone so much for joining us today. We're excited to welcome Dr. Kyle Conway as our speaker for this month. Dr. Conway is an assistant professor of pathology in the neuropathology section at the University of Michigan. His clinical work includes surgical neuropathology, muscle nerve pathology, and participating in the neuropathology core of the MADRC. His scholarly interests include a focus on vascular diseases of the central and peripheral nervous system. And with that, I'll turn it over to Dr. Conway.
All right, great. Well, thank you very much for that introduction, and thank you for having me. Am I sharing my screen? Okay, great. So this is a somewhat wordy title, I guess, but basically to kind of give you a sense of where I'm coming from. As Courtney mentioned, my primary involvement in the ADRC is in my clinical work, which is to say that I do evaluations of brains to provide diagnoses for families. And I think, you know, I'm not somebody who is a physician scientist and I don't have a lab. I kind of approach this from how can we do that part of our job better? And how can we think about some of these things from the clinical end? And so, you know, the overarching kind of goal I have here is to put together some of the differences that we can see in pathology in the kidney and in the brain. And kind of going back to my point about being, you know, more clinically focused, the genesis of some of the things that I'm going to be talking about were from my time at University of Iowa when I was working on the renal pathology service as well. So I would sign out kidney biopsies, and I noticed certain kind of similarities and differences in the way we think about vascular disease in the brain and the way we think about it in the kidney, and especially in these neurodegenerative cases where vascular disease is super, super important. I wondered if maybe this can kind of better inform the way we think about some of these things. So the picture I have here, you'll see lots of these just old school H&E stained sections that are collected as part of routine diagnosis in our neurodegenerative cases. This particular picture is the choroid plexus, and I think the choroid plexus is very interesting in that it's this is the structure in the CNS that is used to create cerebrospinal fluid, and it functions kind of similarly to the kidney in that it acts like essentially like a big filter that you can see. We have these vessels that are kind of like a sort of a medium caliber artery, these kind of small arterioles, and then all these little epithelial cells that are used to filter. So you'll see some similar pictures as we go on, but I think it's just kind of illustrative to the connection that we have between these different parts of our body. So the topic that I'm going to talk about kind of over and over again today is arteriosclerosis, which is really just a term that means hardening of the arteries. And this is in pathology probably one of the oldest concepts. This goes back to antiquity, but Rudolf Virchow, who is kind of the father of modern pathology, gave some of the pathologic descriptions of arteriosclerosis in the 19th century. And so again, arteriosclerosis is just a very general concept that is an interconnected set of pathologic changes to arteries throughout the body in different sizes and in different organs. So if we were to look at the brain, we can kind of think about, you know, this branching of arteries from these large arteries like the middle cerebral and anterior cerebral arteries that come down and branch into sort of medium caliber arteries, and then small arterioles. So they become, the circulation becomes smaller and smaller as it penetrates deeper into the brain. We have different processes that affect these different arteries. And again, arteriosclerosis is a very general term. People have come up with different ways of classifying it, and the way we classify them is important for how we make diagnoses and how we think about things clinically. So, one way we can look at the classification is we can kind of go by the arteries affected. So we think of our atherosclerosis as being a feature that affects large arteries. That's usually what would cause like an infarct, a cerebral infarct. And then as we go down to those, medium caliber arteries and these small arterioles, we have different processes that affect them. And I'll kind of talk sort of in turn about how these are important to what we do. We care about these different patterns because they can have different clinical correlations, and especially for our purposes, we really think about how do these things associate with cognitive impairment. So for that reason, a lot of these are routinely documented in neurodegenerative cases as part of our standard reporting according to the NAC neuropathology data set. And you can see there's a few of them here. Arteriolosclerosis, which is what I'm going to talk about the most. So I'm saying arteriosclerosis, meaning the overarching term, and then arteriolosclerosis, meaning changes to those very small vessels. Atherosclerosis of large vessels, and cerebral amyloid angiopathy, which I'm not going to talk about much today, are kind of the three big important ones that we routinely document in these cases. And if I kind of go back to this, overall schema, we see that they're all kind of encompassed in here. So atherosclerosis, we assess that by looking at the vessels of the circle of Willis, and this is like plaques in large arteries that result in stroke. What we call Mankeberg's medial sclerosis, or calcific atherosclerosis, or arteriosclerosis, is calcification of small vessels. This is less important. We think of this as kind of a non-specific age-related change. Cerebral amyloid angiopathy, which is deposition of amyloid that you usually see in association with Alzheimer's disease. And then what I really want to talk quite a bit about is arteriolosclerosis of those small vessels. You will note, so both of these kind of categories that they call hyalinosis, and I'll talk more in detail about this, which is sort of deposition of plasma proteins, and fibromuscular intimal thickening are both within this category of arteriolosclerosis. You'll note that this is really important for what I want to talk about today, but this kind of intermediate feature, which is fibromuscular intimal thickening of medium caliber vessels, is not really something we think about. It's not in the NAC form. It's not something we document routinely in neuropathologic diagnosis. And that's something that I think is really important that I want to talk about today. But let's focus on arteriolosclerosis first. If you have any interest in vascular disease in the brain, this is a really amazing review paper that talks about arteriolosclerosis and all its different forms and its etiology and pathogenesis and clinical correlations. But the most important part about it is that there's no set feature for what we call arteriolosclerosis. And again, this is a diagnosis that we're going to be making typically at autopsy when we have taken sections of brain that we're trying to make a neurodegenerative diagnosis on. You can see that in this paper, they reference multiple different definitions. All of them, generally, kind of what unifies them is that this change happens to vessels typically in the subcortical white matter, and they're generally considered to be vessels that are less than 150 microns in diameter. All of these vessels are connected, so there's no clear spot at which you go from being a small arteriole to a medium caliber artery, but we kind of come up with arbitrary definitions. An important part of it is that it commonly has what we call hyaline change or hyalinosis, which is really, again, just deposition of loss of smooth muscle, deposition of plasma proteins, and kind of this, when we use the word hyaline, we really just think of this kind of pink, amorphous pink material that accumulates. So if I were to show you a section, an H&E stained section of subcortical white matter in the brain, your typical arteriole, which I have, this one measured down here, so say that's 140 microns, so we're under that definition of 150 microns. Typically, you kind of have this thin layer of endothelial cells and a couple layers. These little blue cells here are smooth muscle cells. So that's kind of the typical structure of an arteriole. When you undergo the process of arteriolosclerosis, that vessel thickens, and this kind of pink material is what we would call that hyalinosis. And you've lost these smooth muscle cells here. They're gone. And what happens is that this vessel loses its elasticity because of that, and it becomes constricted, and it becomes firm, and that's kind of why it's under this umbrella of what we call arteriosclerosis, or hardening of arteries, or in this case, arterioles. There's a few secondary changes that go along with it. For example, you get this dilation of the perivascular space around it, which is commonly seen in on imaging as well. You get deposition of this little yellow material here is hemosiderin. So the idea is that essentially as this vessel thickens and loses its elasticity, it also becomes permeable, and you get those plasma proteins depositing around the vessel. And then kind of the ultimate long-term consequences, you start to lose myelin or white matter around it. So the idea is eventually these changes will result in cognitive impairment, probably through destruction of the brain parenchyma around these small vessels. This is a very difficult pathologic feature to really classify, because there have never been traditionally great set ways of describing it. This is just kind of something you learn to recognize, and people talk about. Some people have come up with schema to try to define how we think about arteriolosclerosis. And I think probably one of the best and most useful ones is this vascular cognitive impairment neuropathology guidelines, or well, referred to as the VSING criteria. Basically, what they did is they looked at all of these many different parameters: arteriolosclerosis, meaning just the vessel wall changes that I talked about, perivascular space dilation, hemosiderin leakage, myelin loss, the things that I showed you in that last photo, as well as kind of the sequela of these things, right? So ultimately, you think if you have vascular changes to the brain, it will result in either microinfarcts, large infarcts, these are just another term for a stroke or infarction, lacunar infarcts, hemorrhages. All of these things are kind of thought to be the result of these small vessel changes. And what they did essentially in this paper is they graded them, and this is a traditional way to do it, from none, mild, moderate, or severe. And they got a large group of neuropathologists together to try to see how reproducible these things are, and then also how well they correlate with cognitive impairment. And the main kind of point of this paper is that really, again, cerebral amyloid angiopathy being something that's out of the scope of what I'm talking about today, but the presence of infarcts and the presence of severe, moderate, or severe arteriolosclerosis, again, as defined by morphologic analysis, is associated with cognitive impairment. So we have good evidence that this change in the brain is associated with cognitive impairment. How does that happen? That's kind of an open question as to how much of this cognitive impairment is due to the results like infarcts versus changes actually attributable to the arteriolosclerosis itself. So were I to tell you that arteriolosclerosis can lead to cognitive impairment, it can lead to myelin loss, infarcts, and hemorrhages that we would think also will result in cognitive impairment. The question I'm kind of more interested in is what leads to arteriolosclerosis, or what clinical associations do we have with arteriolosclerosis? And this is pretty well defined, that the three biggest factors contributing to it are aging, diabetes, and hypertension. What I think is very important here is that these studies are done typically in brain banks and places just like the Michigan ADRC, where patients have donated their brain. Typically, patients, either control patients or patients with a neurodegenerative disease. And when they do that, they provide clinical history, and we can know certain things about them, like they can report a history of diabetes or hypertension. And most of these studies on arteriolosclerosis say reported histories of hypertension or diabetes are associated with this change. But I think what's really important to know is that, to think about, is that both of these things are very dynamic diseases. Hypertension, a patient with hypertension may be well controlled for a long period of time. Same with a patient with diabetes. Or a patient may have very severe hypertension for a very short period of time and die at a young age from an intraparenchymal hemorrhage. or a patient, there's all sorts of different ways of thinking about the cumulative injury from these two processes. And I think, an area that I studied when I was a medical student was looking at patients who had 24-hour blood pressure monitoring, right? And if you look at anyone, you were to put a blood pressure cuff on them that records over certain periods of time, you see that even within a day, patients have wide varieties in their blood pressure. So there's a dynamic injury to vessels, both over days and lifetime. So I kind of had this question of, is there a better way to measure this area under the curve when we're looking at the relationship with arteriolosclerosis than simply having a yes, no, do you have diabetes or hypertension? And this is where the kidney comes in, because the kidney is, patients kidneys are frequently biopsied in patients with kidney disease to establish the etiology of that, of their kidney injury. And because of that, we know really clearly what the clinical associations are between the pathologic changes in the kidney that we see in diabetes and hypertension. And I really want to talk quite a bit today about this change, which I'm going to call medium vessel arteriosclerosis, for lack of a better term. You could call this intimal proliferation and medial thickening, but that's a little bit wordier. But I just want to distinguish this change from arteriolosclerosis. So this is a change to vessels that are more of a medium caliber. So this one I've measured here is about 230 microns in diameter. So over our 150 for arteriolosclerosis. This is a vessel in the kidney. And you can see that typically they have, you have two layers that we really care about to the vessel wall. This is that medial layer with all these smooth muscle cells, and the intima, which is kind of an elastic material that, again, gives the vessel its elasticity. In association with hypertension, you commonly see this change, which, again, I'm going to call medium vessel arteriosclerosis, which is proliferation of that intima layer and thickening of the media. So the idea here is that, and this is a change that happens in response to shear and pressure and stress that results in proliferation of these layers of the vessel. This change is not specific for hypertension, but is commonly seen in patients with hypertension and as patients age as well. So if you kind of went back to this overall classification I had, this would be the thing that I said we don't really think about in the brain: fibromuscular intimal thickening or medium vessel arteriosclerosis. In contrast, we can distinguish the changes of diabetes in the kidney. So this is a glomerulus, which is kind of the main filtration structure of the kidney and is made up of these kind of small capillary loops. Normally, it's sort of open. It has this afferent arteriole that comes in, brings blood in, which is then filtered and ultimately excreted. We know characteristic changes that happen in association with diabetes, which is that you get deposition of those plasma proteins similar to arteriolosclerosis in the brain in this, what we call the mesangial space here, ultimately forming these kind of nodular changes. And you often see along with it what we call in the kidney nodular hyaline arteriolosclerosis, which is, again, similar to arteriolosclerosis in the brain, except that it kind of forms this more like nodular accumulation of those plasma proteins. So the point I'm trying to make here is that in the kidney, you can see changes that are somewhat distinct between patients with diabetic type of injury and a hypertensive type of injury. And what's important, I think, about both of these, and I didn't say this, but I'll just go back to say that there are methods for quantifying this. You could measure these vessels, but we typically in practice there are people will grade this as sort of mild, moderate, or severe, depending on the degree of luminal occlusion. These have been codified in various consensus guidelines as well, because these things are important in various disease processes. And just as you can quantify arteriosclerosis, mild, moderate, severe, there's classification systems for diabetic nephropathy. So you could say the earliest you only see by electron microscopy, so we don't really care about that. When there's some mesangial expansion, we call that class 2. When it's developed that sort of nodular change, it's class 3, and when it's advanced, meaning that the glomeruli are starting to scar or die, that's class 4. So we have sort of a way we can track, and my the argument that I'm trying to make is that we can use these measures as a measure of cumulative injury. For example, we know that class 2 diabetic nephropathy begins relatively early in the disease process. You can see this in patients 2 to 5 years after they've developed diabetes. And actually, as it progresses, you see worsening of kidney function. And typically by the time you're class 4, those patients will be on dialysis or in need of a transplant. So the question I had was, can we use those measures, the progression of diabetic nephropathy and medium vessel arteriolosclerosis in the kidney, as a measure of sort of the area under the curve of hypertensive or diabetic type injury, and use that to evaluate clinical associations with arteriolosclerosis in the brain? So the way I did this is essentially just a retrospective look at decedents who had an autopsy performed at the University of Michigan for a medical disease or a natural death. So we're not looking at people who died in motor vehicle accidents, although that would provide a different, I think, perspective on it. These are patients who did not necessarily die with a neurodegenerative disease. And in fact, as I will show you, many did not. And I wanted to capture this across age ranges to kind of see how these things progress. And the advantage of doing it this way is that you can get a large number of cases this way, because if you go back over a number of years, there are many people who have had autopsies performed here for many different reasons. An unfortunate deficit is that it's quite uncommon for a patient with neurodegenerative disease to have a full autopsy performed. Usually, as I've mentioned, those patients have just donated for brain-only autopsy, so we don't have access to the kidney. And my idea here is, as you capture all of these people, essentially you sample the brain, and this is done routinely, and we take fairly standardized sections here as part of our autopsy practice. The kidney is routinely sampled, and I think those two things kind of provide a snapshot in time at the point when the patient died, how much cumulative injury from either hypertension, diabetes, or aging to the kidney did they have, and then how did that correlate with changes in the brain? So basically, kind of in simple terms, I looked at the VSing criteria in the brain, and kind of following their methodology they essentially treat these things as binaries of moderate or severe versus none or mild. So you can treat that as sort of your endpoint. Do you have these things? Do you have arteriolosclerosis? Do you have perivascular space dilation, et cetera? And then the kidney you can kind of grade on a 1 to 3. So this is sort of, I'm going to present you with some preliminary data and tell you that this is sort of a proof of concept. So these are still broad categories. You might get more granular in how you think about these, but I really just wanted to see if you gave this some degree of temporal progression from none to mild or moderate or severe, can you track an increased risk of having brain arteriolosclerosis along with it? So, just to show you kind of typically how this would happen, these are what I'm going to show you are sections from, or what we're talking about in the study are sections that are taken routinely at autopsy. So if you were to take a coronal section of the brain, we would typically in every single autopsy sample some gray-white junction, typically in the frontal cortex, hippocampus, and basal ganglia, that being, I think, kind of a critically important area for some of the things I'm going to talk about, as well as cerebellum, which I don't have in this particular photograph. So again, my idea here was that we would treat these parameters as our independent variables and do essentially a binomial logistic regression with a yes or no of the VSing criteria as the dependent variable. And we know again that these things correlate with cognitive impairment, but I'm trying to kind of give us some more information about what leads to them or what associations they have. So again, preliminary data that I just kind of put together to give you a sense of the cohort. We have at this point, I've collected data for about 118 cases. You will see that it's extremely common for patients to have some history of hypertension, fairly common for a history of diabetes. Again, this is certainly enriched. This is not a representative cohort of the community living population, because these are patients who have had an autopsy performed here, which means they were probably more chronically ill than or enriched for these chronic illnesses. As you can see, there are not many cases I have here who are patients with dementia. This is something that I think is, I'm using this as a proof of concept to show these relationships, and I think I would love to be able to, at some point down the road, replicate what I'm doing here specifically in patients with cognitive impairment, and see how they relate. But you can see that these patients kind of have a broad selection of causes of death. Brain arteriolosclerosis is relatively common in here, and I will just, the ultimate goal here is that most of this work is work that I have done looking at the kidneys and brain blinded to one another. And I'm going through the process of, ultimately when we're done with this study, every one of these parameters will have been evaluated by at least two neuropathologists or renal pathologists, so that, to account for change to the inner observer reliability of these parameters.
Kyle, can I ask a question, Hank, here?
Yes, of course.
When you talk cause of death, vascular, that would be everything from heart attack to aneurysm rupture to stroke in the brain?
Yeah, absolutely. Absolutely. 100%. These are written in very broad terms, just to kind of give a sense. Yes, any of those things, including a stroke or an intraparenchymal hemorrhage, I would have classified under vascular for these purposes. Yeah. And then, so as you can see, we also kind of have a nice, essentially spectrum of progression from of diabetic nephropathy as well as renal arteriosclerosis. So when you put these things all together, I think the results are quite interesting, which is to say, if you do these in univariate analysis, so just up front trying to establish these relationships. So essentially what I'm showing you here, this odds ratio is, these are so age, again, per 10 years. Each of these coded in a 3-tiered process, right? So this odds ratio is with respect to each increase in severity, from mild to moderate to severe, or from none to class 2 diabetic nephropathy, class 2 to class 3 or 4. You can see there's a very, very strong relationships here. In multivariate analysis, so this is controlling for these 3 parameters together, I think it's notable that they all remain, yet diabetic nephropathy seems to have a particularly powerful relationship here. Now, I would caution that these numbers are not really made to compare to one another, because going from no diabetic nephropathy to, class 2 is not necessarily the same as going from mild arteriolosclerosis to moderate, but nonetheless gives you a sense of how these relationships relate as they progress. The other parameters in the VSync criteria, like perivascular hemosiderin dilation and perivascular space, or hemosiderin deposition and perivascular space dilation, do not show any clear associations. I think another study I would like to do is looking specifically at patients with infarcts and hemorrhages and lacunar infarcts and all these features of parenchymal injury, but I didn't want to diverge from my study design to capture those in this particular study. I think that's something that the prevalence of those in our general autopsy cohort, that meaning outside of patients with who came in through the ADRC, is too low to really assess here. The only other parameter that showed any significant relationship was myelin loss. And I think what's kind of notable about that is once you do the multivariate analysis, age is the only factor that seems to be important for myelin loss. The reason that happens is because, of course, renal arteriosclerosis also worsens with age. But I think this helps to establish that this change of myelin loss may be more of an age-related phenomena specifically, whereas brain arteriolosclerosis tends to be less age dependent, even though age still plays a role, of course. So if you were to put these two factors together, just to kind of illustrate the significance here, I think, and look at individual cases, yes, no to whether there's brain arteriolosclerosis, and then as you progress through diabetic nephropathy and renal arteriosclerosis, what I really think this shows is that patients on the very severe end, so patients who have especially end-stage renal disease, it's very uncommon for these patients to not have arteriolosclerosis. I would say the patients with very severe kidney disease will also have very severe vascular disease in the brain. Maybe not a surprising conclusion. The same is true of renal arteriosclerosis. The difference is that this washes out a little bit more when you put them together into a multivariate analysis. So I just took a couple photos of what I think is a really, really instructive case, which was this was a young patient in their early 50s who had, this is that nodular glomerulosclerosis that you would see in diabetic nephropathy. This is that nodular arteriolosclerosis. And if you look at the brain, this patient has what we would call quite severe arteriolosclerosis. In all of these patients, it's pretty uncommon for somebody without diabetes to have this extent of arteriolosclerosis in the brain. So I think this is really kind of an instructive example to show how strong this relationship is. So to go back to that first research question I had, I think we show that age, renal arteriolosclerosis, and diabetic nephropathy are all associated with increased odds of brain arteriolosclerosis that are not clearly associated with the sequela of them, that is in the form of perivascular space dilation, hemosiderin deposition, or myelin loss. So this kind of led me to a second question, which is, if I'm talking about arteriosclerosis of medium vessels in the kidney, why am I not talking about that in the brain? And why do we not think about that? And why is that not part of our, part of our data that we routinely collect at autopsy? And again, just to go back to it, what I'm really talking about here in this whole spectrum of arteriosclerosis is fibromuscular intimal thickening of medium vessels. What's kind of interesting is there's historically in the literature been described a distinction in arteriolosclerosis in the brain between what people call hyperplastic, or sometimes you'll hear the term onion skinning, but this is a change that looks similar to that fibromuscular intimal thickening in the kidney, as opposed to the more clear hyaline arteriolosclerosis that we think of. Somebody decided at some point, or through accumulated evidence, that it was not easy to distinguish between these two, or it didn't matter to distinguish between these two. So that distinction all sort of fell under the realm of arteriolosclerosis. Again, we're looking at small vessels here, less than 150 microns. But in fact, both the kidney and the brain, you can sample those medium caliber arteries, right? So if we were to look, really down here, what I'm showing you with the arteriolosclerosis are those small arterioles, the same up here in the subcortical white matter. But if we sample the basal ganglia, which, as I've told you, is routinely sampled in our autopsies, you can capture that same caliber of artery, which I might say is between 300 and 800 microns in diameter. And those are typically the arteries that we think of as the lenticulostriate arteries that penetrate into the basal ganglia, and probably what we think of as being associated with intraparenchymal hemorrhages in hypertensive patients. And in fact, I could show you, I think, that this lesion can be seen in the brain just as well as it can in the kidney. So here's a typical penetrating artery in the basal ganglia. This one I've measured over here, 500 microns. This one would be about the same. But typically you have a very thin, this is our intimal layer, which is this little elastic band. And then, this is the thickness of that medial smooth muscle layer. There's certainly cases which, in my clinical experience, I believe historically to have seen in patients who have a lot of evidence of hypertensive type disease that have especially prominent intimal thickening. So this is that elastic layer right here, and you can see it's sort of proliferated into many layers down here. Now, what I will tell you, and if you are kind of thinking about the picture I already showed you, this isn't quite as prominent as it is in the kidney.
Your arrow is really small. If you could make your arrow bigger, it'd be easier for people to see it. I don't know if you can do that.
Thank you. I do not. Is there a way for me to pointer options? There we go. Is that better? Can you see? Oh, am I not?
Now it's a red dot. Okay, good.
Okay, you can see it. Okay, good. I was worried for a second that you were not seeing it at all, or I was not showing it at all. Thank you for that, Hank. That's helpful. So yeah, so this layer here, which is the intima, has markedly proliferated in this particular vessel. And what I would like to do is make the argument to you that this is a change that corresponds to a similar process in the kidney. So if you look back at the analysis that I told you I did before, where you look at age, renal arteriosclerosis, and diabetic nephropathy, and use our endpoints as the VSIN criteria, Let's do the same thing now and think about those medium vessels, those medium caliber vessels in the basal ganglia, or you sometimes may sample them in the cerebellar white matter as well. And I think the question here is that I honestly think is not quite as clearly answered in the literature as how well does that change associate with cognitive impairment? That question is not really answered because it's never been asked, right? And we would assume, because these are typically the prominent vessels in the basal ganglia, and these are the lenticulostriate arteries, that we would assume pathologic changes to these vessels probably correspond to parenchymal injury in those areas as well. This is a little bit more of a challenging question to ask, I think, partly because arteriolosclerosis has a lot of literature and there are criteria that I've described to you, but we don't have that for medium vessel arteriosclerosis in the brain. So for the purpose of sort of this, again, proof of concept study, I think with enough consensus from multiple neuropathologists, I think this can be coded sort of as a binary of, is there evidence of intimal proliferation and medial thickening as a morphologic impression? You can certainly use measurements and have a continuous endpoint. The challenge to that being that really, if you're measuring a ratio, it's a little bit challenging unless you have a perfect cross-section of the vessel. And in fact, even this really nice example that I've shown you is not a great cross-section, because you can see that it's a little bit longitudinal as well, but I just use it to illustrate. And these penetrating arteries, these are complex three-dimensional structures, and we're taking a single typically a single coronal section through this area. But you could measure, and people have done various things. Like, for example, in the realm of atherosclerosis, it's common, through other means, not pathologic means, but through ultrasound, to look at things like the intimal to medial ratio, the ratio of the total wall thickness, things like that. If we use that simply as a binary endpoint, yes, no, is there evidence of any vessel that shows intimal proliferation and medial thickening? What's interesting is we see the same relationship between age and renal medium vessel arteriosclerosis, but we do not see the relationship with diabetic nephropathy. This is kind of an intuitive result. Basically, all I'm telling you is that the small vessel changes in the kidney correspond to the small vessel changes in the brain, and small vessel changes in the kidney do not correspond to medium vessel changes in the brain. I would use this as an argument that this is a change that is more specific for hypertension compared to brain arteriolosclerosis, which is not quite as specific for an etiology. And in fact, were you to do your best effort to measure a ratio in terms of, this is essentially a measurement of how in a cross-section, when you are able to capture these arteries in cross-section, how occluded are they? And there's clearly, as renal medium vessel arteriosclerosis goes from none or mild to moderate to severe, you see a corresponding change in the worst vessel in the basal ganglia as well. So again, just to kind of put this up against this similar chart where that I showed you before, where the outcome was arteriolosclerosis, we can see that these relationships between age and medium vessel arteriosclerosis remain, but the relationship with diabetic nephropathy does not. And in fact, as renal medium vessel arteriosclerosis worsens, you have a greater risk of developing the same lesion in the basal ganglia as opposed to developing arteriolosclerosis in the brain. So essentially, I can sort of answer that second question as seeing that age and renal arteriosclerosis are associated with medium vessel arteriosclerosis in the brain, but diabetic nephropathy is not. So again, just to kind of summarize everything I've said in a simple way, is that small vessel changes in the kidney correspond to small vessel changes in the brain, and medium vessel changes in the kidneys correspond to medium vessel changes in the brain. Why do I think this is important? Well, I think the reason is I think it's useful for us when we are making diagnoses to to separate out lesions that may be more indicative of hypertension than lesions that are not. I initially kind of came up with this idea as, what's a better way that we can diagnose hypertension in a brain at autopsy? And I think this is one way to do it. However, I think there's a more important part, which is that if this truly is a distinct lesion, it may be important for us to be documenting this and as a tool for future research. I think it's kind of important to know whether this lesion exists or not in kind of determining associations with clinical outcomes and cognitive impairment. So just a few kind of, I think there are, again, this is sort of a preliminary and proof of concept sort of study. So an important part is that this is all associative. The changes, the medium vessel arteriosclerosis in the kidney is not diagnostic of hypertensive injury. It happens with aging. It happens in a number of different scenarios, but it is the most characteristic lesion, and I think is the earliest place that you see it. I think it's interesting. For example, we do see it frequently in temporal arteries as well. That you tend to have a greater degree of this change than you would see in the brain as well. So I think there are places that are sort of early flags for it before it happens in the brain. Again, I have limited sampling here. I told you that we have three important sections that I've looked at that are routinely taken. If this study were to be done in the setting of the ADRC, we would have 14. So I think it would be, in an ideal world, we would have this information in patients who are donating their brain for neurodegenerative disease as well. It would be great to be able to correspond to the full spectrum of pathologic changes that we see. Of course, we're still in all vascular disease in the brain at diagnosis at autopsy. We're still at the level of doing these from a morphologic point of view. This is not me alone. This is how we do it as a general rule. And even the VSING criteria that I showed you do not have perfect inter-observer reliability in determining what is arteriolosclerosis is not. And then again, this is really kind of a cohort of patients that do not clearly have dementia or primary neurodegenerative diagnoses. So I think it would be, we are a little limited in how much you can generalize that to patients with neurodegeneration. I think there's a lot of things you can do with this tool. Like, were you to have this information in the full spectrum of patients, it would be interesting to know, I talked about calcific arteriosclerosis in the brain, cerebral amyloid angiopathy. It would be interesting to know what systemic pathologic correlates are associated with these changes, because we don't really know that. And then again, I think, the other important future direction here is distinguishing between these two lesions, brain arteriolosclerosis and brain medium vessel arteriolosclerosis, as distinct lesions that may have different implications for cognitive impairment or other things that we care about here. So with that, I do not have a lab, but I have many people who have helped me out with this and will help me out in the future, and both excellent residents and neuropathologists and renal pathologists who are, I think, want to treat this as rigorously and really kind of like close the loop on everything here to really clearly establish these associations. So thank you to everyone who has helped. Here are my references, and I will take any questions.
Kyle, that was a great talk. As somebody who has very minimal knowledge in pathology, you did a fantastic job explaining all of the elements. Thank you very much. That was great. Oh. Let's open things up for questions. We've got about 15 minutes for questions and discussion. Go ahead, Hank.
Thanks, Kyle. Really great talk. I came in a little late, so I missed a few things. Sure. I'm kind of struck when I see the autopsy reports is that the extent of, you say we do a great job in the dementia space of detailing the various neuropathological features, but the actual description of the cerebrovascular changes is quite limited. And clearly that needs to change in some way. Maybe it can really be focused in a more quantitative way on those three particular areas that you talked about, the hippocampus, the basal ganglia, and the cortex.
Sure.
But it strikes me as being inadequate right now. And I just want to know your thoughts first about that.
Yeah, I mean, I would say the reason that I came up with this idea is because I do think it's inadequate. And I don't think it's inadequate in the sense that, we're doing anything inadequate. I think it's our community in general. It's just it's challenging these are widely varied lesions, and they're difficult to quantify and they're difficult to classify, and it's difficult to get people to agree on definitions for different things. So, and I would say part of it is that, again, going back to like our NAC neuropathology data set, it's as limited as, is there arteriolosclerosis? Is it mild, moderate, or severe? Is there myelin loss, which I can't remember. I think that's mild, moderate, or severe. I don't know if that's a yes or no. And then atherosclerosis, which is entirely based on a gross impression. We don't take sections of the large vessels of the circle of Willis. And then, amyloid angiopathy, which I think we do a better, we do that a little bit more comprehensively because we're really looking at that in a rigorous way in a lot of different areas. So I think, yes, I think there's a lot of room for being more granular and more specific in how we describe cerebrovascular disease in the brain. And I think, there are certainly many people who are making efforts to improve the way we do that. And certainly like the VSING criteria, I think are a great starting point for a lot of that. And, I'm just kind of, what I think here is that this is a tool for us to know if we have this. I mean, it would be a fantastic world where we could, when someone donates their brain to the ADRC, that we could also get a kidney biopsy at that time. That's probably unrealistic, but I think this was a great tool for telling us, which of these lesions are pathologic, which are important, which are associated with systemic disease, as opposed to maybe there's a whole spectrum of these things that people may dismiss as non-specific age-related changes, or something similar to that. And the other thing is, I think there's just a wide, taking us outside the spectrum of outside of the ADRC specifically, but just neuropathologists throughout the country and the world, I think vary a lot in their terminology, first off, in how they were trained. Some people will see arteriolosclerosis and call it hypertensive arteriolosclerosis or hypertensive vascular disease. And I think, so I think we're still, despite this is what I find kind of fascinating. This is such an old topic that, Virchow and in antiquity, people were writing about this. Yes, I think it's just something that we have not in other areas where we can more clearly define things with, with our immunostains or with molecular testing. Like, we don't have the ability to do that here. And, so I think, yes, that's a long-winded way of answering your question to say, I think we can do better. And hopefully, I think, this can be part of that.
Thank you.
Mm-hmm. Emily, did you have a question or?
Yeah, I did. Oh, yeah. And then I'll also echo what you said about like, I feel like I'm in this cohort of people, like neuropathologists, who get like very distracted and interested by like all the aggregates and like mostly ignore the vascular changes.
Yeah, I mean, I think
guilty as charged.
I think that's most of us. And to be perfectly honest, it wasn't until I learned renal pathology and was working in renal pathology that I was starting to make some observations of things that I was like, oh, I never really learned this distinction, or we don't think about this. And so much of the way we talk about vascular disease in general and arteriosclerosis in general is defined by renal pathology. Like they think about it very extensively, and there aren't many renal neuropathologists. So there's not a lot of crosstalk, I think, between the two communities. And I think this is a way to, vessels are vessels wherever they are in the body, right? And the brain is different in its ability, certainly in its ability to auto-regulate its blood pressure, right? So I think that's probably one reason we don't necessarily quite see the same extent of changes. But I think, this is I think the more you kind of think about these things and pay attention to them, I think the more that we have an opportunity to do a better job with this.
True. So really quick, I guess I had two questions about like kind of that I thought could like I don't know, close loop or like even make this association tighter. So these were all patients at Michigan Medicine. So you actually do have data on whether they had hypertension and diabetes, right? Like you don't have to like only rely on the renal pathology. So do you have any plans or thoughts about going through and just taking something simple like, I don't know, a hemoglobin A1C or like, I don't know, or even like yes or no, they're insulin dependent, or like how many hypertension medications they're on.
No, that's
like,
a great idea. I have not collected the full spectrum of hypertensive changes. It would be interesting to correlate with like in some of the work that I had done before. That is info we collected as like how many hypertensive medications are you on? And I think that's important. What I will tell you is that A1C has no relationship whatsoever.
Well then don't do that.
And I think the reason for that is A1C is it gives you a 3-month window into what it's on, but it doesn't necessarily tell you, like somebody could have an A1C of 7 for a long period of time, or 13 for a short. And I do think that hypertension is a little bit more nebulous, because I think the medium vessel arteriosclerosis has a lot of confounding things. But the diabetic nephropathy, I think we're pretty good at, like those clinical associations are pretty clear, and I think that's a better way of like really telling us that. But your point is totally well taken. I think it would be very cool to have really more. I mean, in another fantasy world, I think it would be great to have data on 24-hour blood pressure, because even if you take somebody, like if you were to know in the year before they died or before you had all this info, were you to know, like if you put a 24-hour blood pressure cuff on somebody, you can actually get a lot of information about how elastic their vessels are, and what, that there's a lot of information even just in that limited window that I think would be interesting to kind of correlate to some of these changes too. But I'm limited in my ability to go back and look at what we've already collected, but there's absolutely certainly more clinical information we can collect too.
Emily,
okay, and then sorry, I have one more question. I'll be quick. So basically, like I was pretty interested by the fact that the myelin loss. So the myelin loss did you analyze like arteriolosclerosis or like thickening of the vessel wall with the things that we think about as sequelae of AS? Like is there a close association between, for example, myelin loss, hemosiderin, et cetera, and like
there is not. Yeah, that's a great question. Honestly, off the top, I did that at some point in the past, and I don't remember there being clear associations. In fact, like it's quite common, especially to see hemosiderin, especially in the absence of arteriolosclerosis.
I guess I wonder, like, I mean, we think of those as sequelae because, like, I mean, it seems like it should be, right? But is it?
I
don't know. Are they really sequelae?
I think that's another question, because I think there's two things that could happen there. One is that hemosiderin and myelin loss especially indicate unsampled arterial. These are not always, these can be patchy lesions. So that may be the case. The other thing is, like, I mean, I definitely feel like I've seen cases in the past of younger people without serious vascular disease who do have like a little bit of hemosiderin, and so I do wonder how much that may be a completely non-specific change.
Or like the myelin loss. I mean, you could imagine that being like actually a driver of vascular changes.
Totally.
Anyway.
Unfortunately, that's great. Unfortunately I'm ill-equipped with this methodology to answer the question. But I think that's a great great point, and I think especially with like late, right? We're now having a lot of questions about like what is that interaction between vascular disease and or ARTAG and these other age-related changes, and which one, maybe those are the driver. And it would be great to know. I mean, if patients didn't have cognitive impairment, obviously we didn't do it, but it would be fascinating to know how many of these patients had late or ARTAG in association with this vascular disease as well.
Yeah, that would be cool.
Kyle, can I ask another question? Those of us who see patients and get films, we always see microvascular changes. They're usually periventricular, and they're almost always present. And yet you're not even looking at the periventricular space. You're looking at the big. So has that been looked at? I mean, I assume it has, because we're constantly saying, oh, it's microvascular disease, but I don't even know if that's exactly what it is. It's rampant in age-related cognitive impairment. And those of us who are neurologists don't really understand exactly what it means. and radiologists will call it every single time.
Right. Yeah. And to the extent that it's almost like is not useful to collect as a parameter in this study because every patient over a certain age will have that finding
Exactly.
radiologically. Exactly. So what I will say to that is that the VSING criteria, they actually recommend collecting specific, this is not, you're getting closer to the periventricular space, but they recommend using the triple watershed of the occipital white matter as a better spot for sampling. Of course, we don't have that here, and that's not routinely sampled. We don't even routinely sample it in our neurodegenerative workups because we sample enough subcortical white matter to get that information elsewhere, I think. But yeah, I don't know the answer to your question as to, I'm sure somebody has done a radio pathologic study correlating those changes to what you see, and I suspect, those patients would have arteriolosclerosis, right? And I think probably more what is actually seen on imaging is probably the perivascular space dilation. I think more than anything else, you're not going to see down to the granularity of the vessels themselves. And again, I don't think I clearly understand the extent to which perivascular space dilation is, a non-specific finding, an age-related finding, or truly a sequela of this. And I think to go back to Emily's point, like you could conceive of doing this in tiers, right? Like you have arteriolosclerosis, and then you count the cases that have arteriolosclerosis plus perivascular space dilation as a next tier, and then arteriolosclerosis plus myelin loss as another tier. And I suspect that probably is some of what starts to account for that. But certainly arteriolosclerosis as a change is extremely prevalent in older patients, for sure.
All right, thanks very much.
Yeah, thank you. Thank you guys for the very good questions.
All right. Any other questions or comments before we close things up for today? All right. Well, thank you so much for joining us, and be sure to join us on April 14th for our next Leaders Initiative seminar. Have a great afternoon, everybody.
Thank you.